Hi all, I'm Dr. Srai and I'm going to share with you a systematic review looking at how characteristics of UK GP surgeries are associated with quality of care. The aim of our study was to understand which characteristics of UK GP surgeries are associated with better or worse quality of care as measured by QoF. QoF, just for those of you who might not be familiar with it, is the UK pay-for-performance system which is designed to incentivise high quality care. And why is this important? Well, GPs undertake 90% of contacts in the NHS, and we know that health outcomes vary between surgeries, from prescribing rates to mortality. This variation cannot be addressed without understanding underlying factors. I'll briefly run through our methods. We included studies investigating one or more characteristics of UK GP surgeries and using statistical analyses to investigate how these were associated with quality of care as measured by QoF. We included studies using national datasets only, with a criteria that they would be including at least 80% of the national dataset. We excluded studies examining performance characteristics and those using QoF as the exploratory variable. The searches were run up to April 2019 and then updated in January 2022. We looked at 4 databases, 2 sources of great literature, and undertook snowballing. The data extraction and quality assessment were undertaken independently and then compared. So what did we find? We ended up with 22 studies. Study designs were cross-sectional and cohort studies which ranged from 2 to 5 years long. They were generally of good quality, with the 3 poorest being of satisfactory quality. 3 were Scottish, 3 English and Scottish, and the remainder English. They used QoF data from 2004 to 2017, but were heavily skewed to the early years of QoF, as you can see. We found 24 characteristics had been examined. Studies varied in the way that they measured the same characteristics. For example, when looking at urbanicity, categories included increasing rurality, non-urban practices, and percentage of urban patients. They also varied in the QoF indicators they used. Some used the whole available QoF set, whereas others selected specific indicators. There were also a variety of QoF outcomes used, such as total points achieved or percentage of clinical points. These differences, as well as the variation in statistical methods and reporting, precluded the use of quantitative synthesis in this review. The first thing that struck us was that the associations were small. For example, regression coefficients for the association between list size and QoF achievement ranged from -0.05 to -0.11. We also found associations between individual characteristics and QoF outcomes were nuanced, as they varied between clinical conditions, the QoF outcome measure used, and the year of study in some of the cohort studies. This meant that some individual studies found mixed associations. For example, finding positive associations between the characteristic and total QoF points, but no association with population achievement. Therefore, for each characteristic, findings were tabulated under positive association, negative association, no association, or mixed association, which was subdivided into varied by conditional indicator, varied by outcome measure, or varied by year. Associations were then categorized by consistency. Consistent was defined as complete agreement in associations. Relative consistency as more than 50% of associations the same, and inconsistent as less than or equal to 50% of the associations the same. The results of that categorization are shown here. The numbers in brackets are the numbers of studies which sought the association. 2 organisational characteristics were consistently positively associated with quality: group practices and training practices. Of note, both of these were examined by the same 2 studies. These 2 studies were undertaken by the same group, used the same QoF outcome measure of total points, and used overlapping years of data from the earliest years of QoF. So they were similar papers, finding similar results. This was the same for nurse staffing levels, which were relatively consistently positively associated with quality, as associations were only positive for some of the conditions studied, but no associations were found for others. As above, these studies were undertaken by the same group, using the same year of study, but different QoF outcome measures. Another aspect of staff mix, the number of full-time equivalent GPs, was also positively associated with quality with relative consistency, as was the caseload of 2 specific conditions, stroke and hypertension. APMS contracts, which was a subgroup within contract type, were consistently negatively associated with quality in 2 studies. It's important to note, however, APMS contracts were introduced with the aim to improve services in areas with poor quality, and therefore reverse causality is possible, where the poorer quality makes it more likely that an APMS contract will be in place. Deprivation was the most studied characteristic, and the overwhelming majority of studies found it was negatively associated with quality. Only 2 studies disagreed. One which looked at individual conditions and found better quality of care for hypertension in more deprived areas than less, and another which looked at overall quality and found that while poorly performing practices were more likely to be located in deprived areas, this relationship did not remain after adjusting for confounding. Confounders were considered to different degrees in the remaining studies, but the difference in this study may also be related to the different methodology used, whereby it focused on a cohort of practices which were the most poorly performing over 4 years and compared this group to the rest. Every study examining list size in England alone found a negative association with quality, either overall or for at least one clinical condition or QoF outcome measure. By contrast, the 2 studies looking at England and Scotland together found larger list sizes to be associated with better performance in some of the indicators for the limited conditions which they studied. However, we noted that both of these studies were disease-specific. One looked at diabetes and the other at cardiovascular disease. They used data from the same QoF year, which was the first year of QoF, and both adjusted for minimal confounding factors. Increased mean age of GPs was relatively consistently associated with poorer quality of care as well. The only study which found no association used a younger age cutoff of over 45 years, while the remaining studies used over 50 years. Again demonstrating the condition-specific relationships of characteristics of GP surgeries and quality, 4 specific disease caseloads were found to be relatively consistently negatively associated with QoF achievement. 3 aspects of patient demographics showed no association with QoF achievement with relative consistency: patient age under 15 years, patient gender, which was only measured as percentage of female patients, and patient ethnicity, as well as a further disease-specific caseload, this time for diabetes, and a specific contract type. The remainder of the characteristics examined by multiple studies found inconsistent associations with quality. It's especially notable that although group practices did show a consistent positive association, single-handed practices did not show a consistent negative association. Furthermore, although list size was relatively consistently associated with poorer quality, numerous studies looking at GP to patient ratio did not find that higher numbers of GPs to patients were associated with better quality. Some of the characteristics examined by individual studies were very interesting. The study looking at dispensing status found that dispensing practices were achieving higher quality of care even for indicators which were not related to medication adherence. And the study looking at clinical computer system found it was the characteristic with the strongest association to quality, even after adjusting for a comprehensive list of confounders. Finally, a quick word about the 3 Scottish studies. They examined 4 characteristics, 2 of which, rurality and GP age, were examined by single studies. As in England, deprivation was associated negatively with quality. However, list size was not. So why was our study great? As far as we're aware, this is the first systematic review to collate and analyse studies investigating characteristics of UK GP surgeries and their association with quality of care as measured by QoF. Using population-level studies with national datasets improves robustness, reliability and validity. And although the limitations of QoF are discussed below, as a widely used, objective, standardised indicator, it retains significant strengths as a measure of quality of care. And what of our study weaknesses? We used a single outcome measure and excluded qualitative studies, limiting the dimensions of quality which we were able to examine. The similar study designs of the included papers means that they were all subject to the same sources of error. These associations do not prove causality, despite it being coherent and plausible for many of the characteristics. And while large data sets have benefits, small differences are statistically significant, which potentially compromises the meaningfulness of a statistically significant result. Studies may not have reported characteristics which show no association. Publication bias is ever present, and lack of data from Wales and Northern Ireland may limit the generalisability of our findings to their populations. Finally, we note the limitations of QoF as a measure of quality. High achievement could reflect more efficient recording or manipulation of data rather than greater volumes of high-quality activity. Additionally, the the studies demonstrated that QoF achievement among UK GP surgeries is almost universally high, with only small differences between the majority of surgeries. While reassuring as a reflection of quality of care, it limits the ability of studies to differentiate performance. Moving on now to the so what of our review. The key implications of this study on research are twofold. Firstly, in identifying potential independent confounders for future studies, and secondly, in revealing the need for better understanding of what factors underpin the majority of variability in quality of care as measured by QoF. Undertaking and amalgamating similar reviews focused on different aspects of quality would provide a more comprehensive understanding of characteristics which influence quality of care. There's also a need to look at reasons for a paucity of published studies in Northern Ireland and Wales, which may reflect reduced funding or prioritisation of quality activities. Current policy in UK primary care places an emphasis on large-scale collaborative working with a shift away from single-handed practices towards more salaried GPs and task shifting to allied healthcare professionals. This review implies the need for caution in this approach. Although group practices were consistently associated with higher quality of care and greater numbers of full-time equivalent GPs relatively consistently so, this must be balanced with the relatively consistent negative association between list size and quality. Furthermore, the inconsistent findings, when examining the association between GP to patient ratio and quality of care, suggest that this is not a straightforward relationship. Similarly, although 2 studies found nurse staffing to be associated with better quality of care in specific conditions, other important staff mix characteristics were only examined in single studies and warrant further investigation, such as the proportion of GPs on the staff, which was also found to be positively associated with quality. Prioritising policy to address the association between deprivation and quality of care as measured by QoF is of crucial importance given the current economic climate. And, given the recruitment crisis in primary care, the findings that greater number of full-time equivalent GPs are associated with higher quality and increasing mean GP age is associated with poorer quality reinforces the need for thorough workforce planning. The variability in associations by condition highlights the importance of careful, targeted quality improvement policies, and the variability by QoF outcome measure emphasises the complexity of quality as a concept. Any quality improvement policy must take this into consideration. Overall, this review alone cannot shape service planning. However, it provides a sound basis for further research. Exploration and identification of the factors which underlie the majority of variation in quality of care is of utmost importance. Furthermore, given the complex, multidimensional nature of quality, systematic synthesis and analysis of research investigating other quality measures would contribute to a more complete picture. Thank you so much for listening. I appreciate your time and attention. Questions and comments are gratefully received at the email address above. Thank you.